Very much, Mr. Chairman, for the nice introduction, and really honored to be part of this masterclass. Congratulations for Dr. Hanan and the team for this amazing masterclass. Inshallah, we'll participate more in the next years. So today I was given the task to talk about immunosuppressive therapies in systemic sclerosis, ILD. I'll be a little bit quick because I know the time. This is more a thought-provoking lecture than a solid lecture. As rheumatologists, we were all qualified and trained to treat patients with autoimmune diseases. But when it comes to systemic sclerosis, we get a brain freeze, even though the options are limited. I mean, if you count the medications, they're less than 10. But this reflects how much the disease is challenging, and it needs a very high multidisciplinary approach, speaking to colleagues locally, internationally, just to reach a consensus on the treatment of the disease. And this is the agenda. And to overcome this hurdle, I think the first step that you need to invest a lot of time is stratifying the disease. You can prescribe any medication, but if you don't have a efforts in stratifying the disease, whether it's diffuse or limited, we had this myth previously that limited patients are less likely to develop ILD, but with an inbuilt trial, the census trial, I believe, it showed that the burden of ILD is as equal as patients with diffuse. We have the myth of patients with diffuse skin disease are more at a higher risk of developing ILD. This is true, but even patients with low skin disease also have a high risk of ILD. And just, as a thought-provoking, 5 years is the cutoff point. Early is 5 years. When we talk about rheumatoid arthritis, it's 3 months. Do we need to wait 5 years to say that this is the earliest disease that we need to treat? And I think as all of you are pioneers in scleroderma, I think we're the future leaders, I think this should be looked into. And when we get frustrated when we apply clinical trials to our real-world evidence, and we apply tocilizumab or rituximab to our patients, and we get, negative outcomes. And I think the major point when we read those studies is what are the collection criteria or the recruitment criteria of those patients? Are they within this 5 years? Or are they more than 5 years? And should we go a little bit earlier? Should we do the cutoff point 24 months, or should we go even earlier to? And this is very challenging. I know it's a very complex disease. Sometimes it's hard to diagnose it as early as 10 months or 24 months. A simple scenario that we see in the clinic, 36 years old, diffuse cutaneous. Her disease started since the age of 32, 4 years. She had a positive ENA, very strongly positive nuclear pattern, high skin disease burden, abnormal nail fold capillaroscopy. And these are her PFTs. And after 6 months, there was a clinically meaningful decline in the PFT, the FVC, the DLCO. Okay, and the high resolution CT showed. So this is a common scenario that we see in the clinic. And to have a successful outcome, I think we need to have this equation. You need to stratify patient clinically, serologically, PFT, high resolution, then echo to have the best outcome in managing those diseases. It takes a lot of time. I'm sure مريض واحد بشيبك يعني. I'm sure all of us have patients. Should we offer treatment to all patients? And as our previous speakers alluded earlier, that up to 90% of patients have ILD. And whom are the patients that we need to invest more time and stratify them? We have the previous points that sometimes it's also hard to apply clinically. And there's also great variability in the treatments. This is a very old study, but I think we're still using it. The window of opportunity is the first 4 years. During the first 4 years, you'll be very highly vigilant with screening those patients because the decline in the first vital capacity happens in the first 4 years. And after that, I think we can say less likely, or the progression of decline is less than when compared to the first 4 years. This is a study we did in the UAE. This is the first scleroderma ILD registry in the UAE. It included about 200 patients, 190 patients, and we focused on our local population. We had 104 patients, and the disease burden is as equal, even as more than what we see even internationally. So this highlighted, the more investment with such master classes, more awareness about the disease, and we did a mix and match patients with ILD, with PH, and as you can see here, the prevalence was 3.7 for ILD, and if you have ILD and PH, 1.2. So the disease burden is there. I think we need to be more vigilant with diagnosing those patients earlier and treating those patients earlier. I think there's a duplicate. Okay, so we have a lot of medications these days. When I was trained, 2017, I'm sure Dr. Hamir, we had 3 options, I think, or 4. We had cyclophosphamide, MMF, Imiran as a maintenance, and rituximab was off-label at that time, or still off-label, but we need to apply for approvals by insurance. You need to struggle a lot to approve it. But these, and recently we had more options, so this is also something that we were really fortunate with to be practicing at this time of era. Okay, so let's go over the trial just briefly. And again, I highlighted the disease duration. Whenever you look at the trial, I think disease duration is crucial. It's one of the most important numbers you need to look in when you apply it clinically from what we call from bench to bedside. I think this is very important. So these are what we call early disease, 3.1 years. And again, 60-40. And you can see 40% of patients with limited cutaneous had ILD. And we are echoing this study or the prevalence of limited in our registry, inshallah. Soon there will be a paper about the prevalence of ILD in patients with limited cutaneous systemic sclerosis. So this was a proof of concept study in 2006, made a big impact on patients with systemic sclerosis. They gave cyclophosphamide IV versus placebo, and then they gave maintenance, and it showed modest improvement of the FVC. And this led to the more larger study, which was published in the New England Journal, but at that time they gave oral cyclophosphamide for 12 months, and then a follow-up period for 24 months, and there was improvement in the pulmonary function test. Do we use cyclophosphamide these days? I think we keep it for more rapidly progressive diseases due to the side effect profile, and with the results from the SLS2, I think this made us to favor more MMF versus cyclophosphamide. This is the primary endpoint, and again there was a effect collapse at 24 months, which also was not, we weren't happy with the results. And then came azathioprine came to the market, or was studied or looked into, and this is also a small study, 60 patients, and again they looked at oral cyclo versus AZA, and the benefit was not achieved with azathioprine. There was a drop, I think, after drop in the FVC and DLCO after stopping the treatment, and this made us not to favor AZA as a first line. It can be given as maintenance, but not for induction. I think SLS2 made a big impact on our treatment or daily treatment algorithm or guidelines, where this was a very landmark study where they looked into, this was the largest at that time, 142 patients, oral cyclo versus MMF, 1.2 BID, and how often we reach this dose. Again, this is challenging. I mean, if we count our patients with 3 grams, I think they're countable. Majority of them cannot tolerate this dose. I think, again, it's very challenging to reach this dose, but it was a positive study where there was a clinically meaningful and significant improvement in mycophenolate compared to the standard of care at that time, which was cyclophosphamide, and this was maintained. And that at this time, I think the guidelines or the consensus changed that mycophenolate is the first line due to the less side effect profile compared to cyclophosphamide. SLS3, this was a proof of, again, of concept study. It was MMF and placebo versus MMF and pirfenidone. And if I go again to 2015, I was running a clinic with Dr. Flaherty, And we used to use pirfenidone. We were, desperate. Patients are refractory, and there's no data. And it was the antifibrotic in IPF, so we used to use what we know from IPF with mycophenolate. And again, there was the primary endpoint was improvement in the lung parameters. And this is some of the study results from us. And there was a modest improvement also in the lung parameters over a short period. I think this is still, it's an ongoing trial. Rituximab, again, this is the first proof of concept study, 2012. It was an open label study where they gave the weekly dose, the pulses, 375, and again, they looked at lung parameters over a 2 years period. And it showed, meaningful findings. And then I think a very relevant question about combination. We combine a lot of therapies, rituximab with mycophenolate. And I think that the concept of this study is to show the efficacy as well as safety. I think the safety was one of the most important part of the study, and it showed that rituximab and MMF are well tolerated, safe, and potential effect for cutaneous and pulmonary involvement. And we do combine, MMF and rituximab. And this is the paper that came later about rituximab versus mycophenolate in the treatment of refractory scleroderma ILD. This was a very landmark study. This is a recent study. One of our colleagues mentioned earlier. It's called the DESIRE study, where they looked at placebo versus rituximab. Very impressive study. I think this made a recent change in our management plans. I was just talking to Dinesh about a patient, and he favored this regimen actually when compared to MMF. So I think this is actually now the to-go maybe regimen that we're using, where they looked at placebo versus rituximab at 24 weeks, and they looked at 48 weeks. At the time, we had the 24 weeks data. It was very impressive. The skin improved, and they were, questioning the trial whether this robust improvement of the skin, is it real or not? And then they went further, I think it's from Japan, to up to 48 weeks. Again, an impressive improvement both in the skin and the lungs. And I think now we are more favoring this in our recent, practice. We're more favoring this regimen. We still combine it with mycophenolate, of course, with caution because of the risk of infections. And if we look at, I think this repeated slide of the magic drug, and with the inbuilt with the census trial, this came I think 2019. We were very impressed by the data, as in whether to use it as a monotherapy in fibrotic disease or an add-on therapy. But again, it was one of the largest, and we learned a lot also from the trial by itself. It was one of the largest trials where they included patients, 576 patients. And of course, most of us know that the findings were impressive. But the thing that comes to mind, when do you start this medication? Every week we have an MDT meeting, and we are always challenged with this question. Do you start it early? Do you start it late? Do you wait? Do you combine it? And if you look, we are about maybe 15 in the room. Each one has a different opinion, so it's again challenging where to put this drug. Inbuilt trial, I think this is the first time we obtain or we extract guidelines for something called progressive fibrosing ILD. It's a phenotype of an ILD that we see in systemic sclerosis and other autoimmune diseases. And this is the first time to inherit criteria from a trial into the guidelines. And it has a certain, points. FVC decline more than 10%. And those patients are followed for 2 years on standard of care, and they had a rapid progressive decline in their pulmonary function test. I think this is something we need to be more aware about, during our practice. This is, so maybe this slide should be a little bit earlier. This is a recent study that we did. We're applying it, we are sending it to the ACR recent ACR 2024. So we looked at the efficacy and tolerability of OFIV, nintedanib. We have 47 patients, and among different disease connective tissue diseases. The most prevalent was systemic sclerosis, and we went 2 months before the baseline, before starting off of, and then we looked at their baseline PFTs. The upper graph is the forced vital capacity, lower is DLCO, and we checked their PFTs at different 6 months, 12 months, and 24 months. If you look up, there was beginning there's some decline, and then there was some clinically meaningful improvement. We also looked at their HRCTs that were repeated at the similar time of the PFT, and there was also improvement in the. So as much as you see improvement in the lung parameters, this is reflected in the HRCT. If you look at the DLCO, I think because some of them developed pulmonary hypertension, there was at 24 months there was a decline, and the variance is large. But this is promising that in our population, this is an Arab population, so it works. Fascinate trial also came with, I was part of this trial at one time. It also made a big change in our practice. Tocilizumab, subcut, 24 weeks, and then there was a longitudinal, and as speakers alluded earlier, it was the primary endpoint was skin, but it failed. And there was secondary endpoint, which is improvement in the lung parameters, and there was a clinically meaningful improvement in the lung parameters, which made, the FDA approved this drug for systemic sclerosis, ILD. Again, we're challenged. I mean, every day or every week we get calls from our pulmonary colleagues, and where to put this, which phenotype of patients that we use this drug, just to give different scenarios from what we learned over the years. If you have an early diffuse systemic with elevated CRP and no early ILD, maybe tocilizumab is an option. If the disease worsens, you go to the next step. If you have more an ILD predominant disease with a very minor skin involvement and MSK symptoms, this is I think one of the best scenarios that you can use the drug. Scenario C is SS-CLD with positive SCL70, because this is a risk score of developing more aggressive ILD in the future. So I think tocilizumab. So these are debatable, but these are scenarios that over the years we learned from experts and internationally. And again, the question comes, if you just, who to treat? I mean, very challenging. I mean, do we treat the first one? Do we treat the second one? We screen patients, we find minimal ILD. Do we wait 5 years to know if they are going to decline, or do we monitor them? A very, very challenging disease. Again, going to our registry, we looked at what DMARDs, and we have good accessibility to antifibrotics, and we were amazed how much we are underutilizing those fibrotics, even though we have a big cohort of ILD patients. Our respiratory colleagues are one of the center of excellence in treating ILD, and still we are underutilizing the medication. So the question comes, are we not providing the appropriate medications to our patients, or are we still not sure having that confidence in treating those patients with new medications that I think from the studies they made a huge impact on the lung parameters. This is I'm sure we spoke about this earlier. This is a simplified screening approach that I was part of with Dinesh and other colleagues, and every patient, as we mentioned earlier, should be screened. High risk factors, you should be more cautious. Baseline CT, high resolution CT PFT, and then refer to an ILD clinic. And this is a consensus I was part of. Dr. Sania Khan is a pulmonologist at Cleveland, and it's in press currently. And we further stratified the disease into low risk for developing ILD and high risk. This is a little bit modified from what Dinesh Khanna did, and I think this makes it more complex, but I think the disease, you need to dig a little bit on the disease given the heterogeneity of the disease. My colleagues alluded earlier to this, that there's a lot of medications coming in the pipeline, which also as rheumatologists will make it very difficult for us to say which patient should fit into that bucket of giving those medications. I didn't add here Benlysta, as one of my colleagues mentioned also, pirfenidone, small molecules, TYK2 inhibitors. I think there's a lot in the pipeline that's coming. With this, I would like to thank you for your attention, and thank you.